internet is not very good.
Hold on, we're live now.
We're live now? Okay, well, people should know how hard you're working there.
Yeah, I'm trying to work with the Wi-Fi, but welcome back to the Incubator Podcast. We are joined by Dr. Martin Stalker.
Yeah, correct.
From the University of Lucerne. You are the head of the Neonatology and Pediatric Intensive Care at the Children's Hospital of Central Switzerland. And you are going to talk at Hot Topics in Neonatology this year about some ways to identify sepsis.
Yeah, I mean, it's going in that direction. So I think, we are giving a lot of antibiotics to our babies.
You don't say.
We've heard that's
yes,
a problem.
probably. It's, some are more aware of that and some less. So that's how it is. And I mean, some of the babies has a true sepsis. And of course, for them, it's life-saving to give antibiotics early. So not that... you saying in the end, oh, Stalker told us not to give any antibiotics. So that wouldn't be the right message in the end. So, but I'm convinced that we can come down on the unnecessary antibiotics because we are giving a lot of them. So in Central Switzerland, for example, we are giving 100 babies, late preterm and term babies, antibiotics to catch one baby with an early onset sepsis. And I just think that's too much. So we have to get better because there is a bad side on antibiotics, and that's the reason why I'm caring about this question and say, oh, we have to get better.
Yeah, but the problem is that we have this loss aversion for the immediate outcome, which is sepsis, which we don't want to deal with, and yet the effects of overuse of antibiotics are a little bit more remote. A little bit more remote, and so we say, oh, all right, I'll deal with that maybe later. And I think that dichotomy has always caused us to err on the side of, I'm just make sure I don't have sepsis. So it would be ideal for us to be able to understand sepsis better, which is obviously a daunting task.
Yeah, absolutely. I mean, this is in the end all about, it's the fear of sepsis, isn't it?
Yeah.
Probably that's one of the big drivers for giving antibiotics. So we say, oh, play safe means give antibiotics. And I think that's just not correct. This may be correct for the next day because oh, I've given antibiotics, I'm on the safe side. But going maybe 10 years, 20 years, we don't know. That's not true. And I mean, you're absolutely right. Probably nobody's coming after 20 years to you and say, oh, you was my neonatologist.
Right.
I think you have given me antibiotics. So I think that's a big problem here. And that's correct. And in the end, what we have to acknowledge, there is never zero risk, isn't it? Of course, we don't want to put our babies on risk. So that's not what we want to do. But on the other hand, if we want to have zero risk, we have to treat all the babies. And I think that's just not reasonable to do. So really, what we have to try is how can we better saying which baby has a true risk of sepsis and which one not. Yeah. And we have to learn what is the basic risk of that. So, and the interesting thing is a colleague of mine, usually if he's giving a presentation, he's asking the audience, he's giving a case and say, what do you think is the risk that these babies will have a culture-proven early onset sepsis? And the answer usually is somewhere 5, 10 to 20%. And if you go back and look, what's the true answer? That it's 0.1%, maybe 0.5 if it's high, So it looks like really we are not really good regarding probabilities. No. But probabilities is difficult, isn't it? Yeah. Because for as humans, that's difficult to handle this. And we don't like to have uncertainty, isn't it? Yeah. We would love to have certainty to say, oh, and then we come to the biomarkers. Of course, there is no biomarkers telling, oh, you have to give antibiotics or not, because no biomarkers is good enough to tell us what we have to do. For sure. And I think that's the challenge where we are in.
I think one of the other struggles is we feel like we don't have a lot of time to make the decision, right? In reality, we probably do have time to watch over time. So how quick are you going to be able to tell us if the babies are at risk for sepsis?
Yeah, I mean, I think, if you have a baby in shock, then we do not have time.
That's right.
But I think there is no question what we have to do. We have to give antibiotics because that's not the time for antibiotic stewardship, isn't it? And on the other hand, if you have a baby on respiratory distress and just on respiratory distress, then probably that's not true that we do not have time. Probably then we have some time and we can observe the baby, what happens, and see, what's going on. And I think in this situation, maybe some biomarkers may help us a little bit, because at least it's an objective marker. The other stuff is a bit difficult because it's not very objective. It's usually, I'm looking on the baby and say, oh, this baby will get sepsis. This one not. I mean, that's just not reasonable.
And you're talking about early, late, both?
I mean, in the end, it's both, isn't it? I think in the late onset is a bit easier because usually we know the baby.
We know more about the baby.
Yeah, we know it.
Yeah.
We have seen it for a week, and so then you have a change. And I think if you have a change, then you need an explanation for this change. And quite often then maybe this could be sepsis. It's much more difficult at the start, isn't it? Because you've seen the baby the first time, and it's just
and you got to
born.
make a decision right there.
And now we have to do something.
But it's
Or
interesting. I'm thinking about recently we've had, I feel like, a lot of workups, right, for babies that we know late onset, and they've not been infected.
No.
Yeah.
And we've done a lot of workups, because it was a baby that we knew who had a clinical change, and it was an infection.
Yeah, absolutely. I mean, in the end, I think really it depends as well, how many sepsis do you really have? So an interesting aspect what we have seen in our studies was the more sepsis, true sepsis that you have, the more antibiotics you are giving.
Yeah.
The more culture negative sepsis do you have. Doesn't make sense to me, no. But probably it's just what you tell.
Self-fulfilling prophecy.
Right. It's what we're thinking about. Oh, I think this one could be sepsis and so. And on the other hand, that what we experience sometimes now, because it's really a fine line, a balance, is that I see a baby and I ask, oh, what you have done here? Oh, we are observing. We're waiting. I said, what are you doing? Observing this one? Are you sure? So so it's really, it can go
Either
on the
way.
other side.
Yeah.
So really, it's a fine balance, and we have to be careful that we are not putting babies on risk for that. And in the end, I think it's a learning process for the team. It's a culture question, And the most important thing for me, at least, is that people are aware of it, that they think about, and I think that's the change that is needed compared to, 10, 20 years ago. Nobody asked you, why have you given antibiotics? It was just the other way. You didn't have given antibiotics? Oh, gosh. So, and that's changing now, and I think that's a good thing to change. So
you've mentioned that every unit is different. Every unit has a different baseline risk of the incidence of sepsis and so on. What are some of the markers that are indicative of sepsis that you've worked on that you find are relatively universal, that apply pretty much to every situation, or maybe not, maybe there aren't any universal? What are some of the ones that we could leave the audience with and say, all right, definitely look out for these?
Yeah, I mean, when we look on the clinical signs, then if you have a baby just with respiratory distress without any other clinical signs, and maybe you even have an explanation for the respiratory distress, then the chance that this baby will have sepsis is not really high. What we have seen on clinical signs is really the cardiovascular instability. So this is a sign that is much more predictive for sepsis than respiratory distress.
Sure.
So I think that's something what I usually say my junior, this is something what you have to look at. Be careful here, because that's critical, isn't it? And then of course, the more premature the baby is, the more is the risk increasing. So I think, of course, with a 24-weeker, you have to be much more careful than with a term baby.
Yeah.
Just looking on the rate of sepsis and the potential outcome, isn't it? Mortality is much higher in the premature sepsis baby than in the term baby. But regarding, it's really this cardiovascular instability together with other signs, then maybe you have some risk factors. The GBS positive mother without any antibiotics, for example, and then maybe it's a preterm baby. Yeah, okay, then it's getting more
Additive.
Additive. Yeah. Yes. But what we realized when we have we just wrote the new guidelines for Switzerland, we realized it's much easier to talk about what has a low risk than what has a high risk. So I think it's really, and then it's more or less the same with the biomarkers when we talk a little bit about biomarkers. So the positive predictive value of biomarkers is very, very bad. I mean, it's not really useful, isn't it? The negative predictive value is a bit better, but we have to choose the right one, yeah? probably not CRP, because CRP needs 48 hours to increase. So it doesn't make sense to use CRP at the start, because it will not increase before the clinical signs are coming. Right. So maybe we have to look for other ones. Maybe IL-6 is better, but that's all difficult questions. And I think in the end, really, it's we need to have an algorithm. We need to take into account risk factors, clinical signs, maybe biomarker, and try to figure out, what is now the basic risk for this baby. And then, I'm asking myself, maybe in different countries, in different societies, is the acceptance of risk is different. Mm-hmm. So maybe in the US it's different from Switzerland or from Sweden. Thinking back on the pandemic, the Sweden, they didn't have done anything for several months because they were just happy to take the risk. Not possible in Switzerland, probably not in the US. So it looks like we need to have a discussion as well about what's an acceptable risk
for sure
to have.
And the resources that are employed. I think that's a big deal as well.
Yeah.
It's a big deal as well. Martin, thank you so much for dropping by and sharing this knowledge with us. Good luck on this work.
Thank you.
And we'll be looking out for more of your research to be published.
Perfect. Thank you so much. Thank you.